Good afternoon, everybody, and I thank Team Diabetes India and Dr. Banshi and all of the people, and Dr. Patak, chairpersons, and Dr. Pratap, who is looking after this special interest group on the elderly. So I have been allotted that how to take care of diabetes in elderly. This itself is the basically the crux of the whole of the topics which will be covered in this group, because right from the understanding that how elderly will change, what is the how the pathogenesis is different, and what are the assessment tools which are different in elderly population, and then finally the management. So it entails everything basically, and it's such a nice thing that we have been discussing about elderly, because just like I have a feeling that just like we have gestational diabetes as a separate entity, I think the geriatric care with increased longevity in India will also require especially special attention to this subset of population basically to address the needs of the elderly population. So thank you very much once again. So this is the prevalence of diabetes in elderly. Although we have younger diabetics in India as compared to Western population, but still the majority of the numbers which are prevailing lies between fifth to seventh decade, or you can say the eighth decade, with a peak reaching around 60 years of age. But the peak does not decline, it declines just because of mortality. There is no reversal basically. So you can see that drop after 60 years is happening because of the mortality of these elderly people, not because of the reversal or any other thing. So geriatrics is a category which is unlike any other. Just you have pediatric on one hand, then you have geriatric on the other hand. So physical and mental functioning is different. Dr. VV Singh was speaking on cognitive decline, so that is the integral part. Very important is economic, social, and emotional deprivation. The duration of disease, we know, when the people get elderly, they are plowed with almost 10, 15, 20 years of diabetes, and they are suffering from, majority of them, from chronic complications. And expected life expectancies, they will vary very fast if you don't address the elderly people. So you have unique challenges in diabetes also in geriatrics. Age-related health concerns, which affects even non-diabetic, then economic, social, and we have already seen the pharmacokinetic changes, the clearances, how the drug is distributed, they are dehydrated, the liver kidney functions, they decline, the fat mass and the muscle mass changes, the bone mass changes, so the distribution of the drugs different. HbA1c is not very reliable in elderly population. We most of the time we rely on HbA1c, but please note then when you're dealing with elderly, especially with the very elderly population, don't rely on HbA1c. I will tell you why later on. Physiological changes, they come in. Tailoring pharmacological treatments is the essence and the key for management, and this is equally important. Nutrition is equally important, which is the most neglected part in old age. And finally, hypoglycemia bars the management of this elderly population. So geriatric syndromes we should be aware of. They do not fall into any disease category. People will come to you that I have dizziness, that I have imbalance, that I have a fall. So I have incontinence, which can be missed like for a urinary tract infection. So suppose you are using an SGLT2 inhibitor and somebody complaining of incontinence. So what is going to happen to that fellow? So immobility, impaired intellect, impaired vision and hearing. Somebody on insulin cannot see the device, cannot see the units. So what will happen to him? HbA1c in geriatric diabetics, as I was telling, in frail elderly patients, don't rely solely on HbA1c because there are so many comorbidities: anemia, chronic kidney disease, drugs. So whatever is going on, the HbA1c is falsely assessed and is not the true depictor also. Even if it is assessed rightly by the lab, it is not the true depictor of the glycemic control in the elderly population. The biological nexus of aging, obesity, and type 2 diabetes plays a complex interplay where the sarcopenia on one hand with frailty on the other hand, and obesity where the visceral fat and the subcutaneous fat plays a role, and there is an inflammatory state, and there is a state of insulin, decreased insulin secretion and increased insulin resistance. Coming to hypoglycemia, it's one of the major limiting factors when trying to achieve recommended levels of glycemic control at any age, but this becomes of paramount importance in older age. A single episode of hypoglycemia will ruin the patient forever. He will not come. It's the theory of weakest link, where the brain is the weakest link in the old age people. Any subtle disease or any subtle insult, whether it is hypoglycemia or any other, will lead to decline in the cerebral functions. So on top of that, there is hypoglycemic unawareness, and then there are poor outcomes, because if somebody suffers hypoglycemia at young age, at least we expect that the cardiovascular outcomes will not be worse. But somebody suffering from chronic kidney disease and cardiovascular disease will suffer fatally with even minor hypoglycemia. So age-related physiological changes, they come in with age, and you just see how the glucagon is behaving. So glucagon is declining. If you see the response to hypoglycemia, whether it's neurologic or autonomic, there is decreased epinephrine secretion when there is minor hypoglycemia. That is one of the reasons for hypoglycemic unawareness. Old age people will have decreased epinephrine. But on the contrary, when this hypoglycemia becomes severe, the blood glucose falls below 50, there will be a surge of epinephrine release, because the responses are slow in old age. When the body will learn, and it will lead to a surge. And what will happen, because of the poor cardiovascular reserve, these patients will suffer some or the other cerebrovascular cardiovascular event in the wake of hypoglycemia. So this is how the old age is playing. Then the living environment, how the people are living, whether they are living in community with the family, they are residing in assisted living facility, or we don't have long-term care facilities in India, but we talk about abroad, then probably they are living in long-term care facilities also. So prevention, screening should be considered as for everybody else. But please note that in elderly and very elderly, the norms are relaxed. The quality of life and the propensity to not to induce the side effects of therapy and hypoglycemia are of paramount importance. And this is how you divide the overall health category of the people. So ADA says this is how you divide the good health, intermediate health, and poor health. I will not go into the details, but elderly people can be assessed basis this, and you will see the different glycemic targets given in the below table. I will apologize for the poor quality of the display, but then you can see that 7.5% in elderly people with good health, less than 8% or up to 8% in intermediate category, and less than 8.5 in those who are not doing well and they have poor health. So that is the target basically. And besides HbA1c, the fasting and the bedtime glucose, these are the two targets which are probably even more important than HbA1c. So you have to have considerations for treatment plans, simplification and de-intensification. So de-prescribing, please note, de-prescribing in older patients is very important, and as the time arises, you should know when to de-escalate. And nutrition needs special mention. Undernutrition, malnutrition, overnutrition, it can happen anyway, but by and large, it is undernutrition and malnutrition. And you can see the two paradoxes over here. BMI more than 30. Again, the patient is frail in old age because he has does not have muscle and bone mass. And if the BMI is less than 18.5, then we obviously know that how the sarcopenic person will be at older age. So shift in dietary strategies should focus on frailty prevention as equally to as glycemic load or glycemic index of the food in diabetics. So that is so optimal total energy intake need to be individualized, high protein intake, vegetable, fish, and healthy dietary pattern, regular meals, and then finally the quality of life as compared to diet. Because if you deprive somebody who is at 85 years of age of not allowing him to eat whatever he wants to, then probably he will not eat and will suffer from undernutrition. So healthy diet, Mediterranean diet is healthy for everybody, for the younger generation also. Physical activity and fitness in geriatrics is important, and these are the various tests. Barthel index should be assessed. 4-meter gait speed, grip strength, these are some of the, and this is the AD recommendation. The 4Ms, we all know 3M, we have been using Littmann stethoscope, but please note that, remember this 4M, right? So mentation, medications, mobility, and what matters most. This is important. This is important, that discussing goals and expectations, symptom and disease burden, meal preferences, risk, burden, and benefits of treatment, side effects, and life expectancy. And these are the different target treatment goals for glycemia, blood pressure, and dyslipidemia in older. Please note that all have been relaxed. Blood pressure of 140 by 90 in group 1 and 150 by 90 in group 3 by ADA. Statins to be used in group 1 and group 2, and group 3, if you feel like, use statin. And similarly, the HbA1c we have already discussed that less than 7.5, 8 and 8.5 respectively in the three categories. So you have to have a simplified diabetes management. I will not go into the details because of paucity of time, and you need to know about the drugs finally. Which drug will have what interaction. Polypharmacy is the biggest problem in old age. They take medicine for osteoarthritis, for backache, for prostate, for whatever diseases they are suffering from. So you need to know the drug interactions and the clearances and the pharmacokinetic properties of all the drugs which you are using, which are contraindicated, and a special mention is required as per the GFR. And this table is given everywhere. We all know about it, but we should remember while prescribing, or rather escalating or de-escalating the treatment in the geriatric population. And finally, tailored insulin approach. The only one thing is, if somebody is on basal insulin, please switch him from bedtime to morning insulin. Don't inject at the bedtime. So that is the change when person is on basal insulin, and somebody who is on premixed, try to shift him to basal insulin along with a drug which does not have a potential to cause hypoglycemia like gliptins. Identifying geriatric syndromes is a vital step. Then you can see here cognitive dysfunction, depression, physical disability, polypharmacy, and so on. You have to precise hypoglycemic dissection is important. With Chairman sir, I will just take 1 minute more. So precise hypoglycemic reduction in elderly with CGMS. CGMS is handy in old age for both the things, to know about the blood glucose, but more importantly to know about the hypoglycemia. So the primary concern for putting up CGMs besides glucose control is hypoglycemia in old age, and there are different criteria. The time in range advocated for elderly people is less than 70% or up to 70% is okay, and time below range should be kept below 4% in group 1 and less than 1% in group 3. So that is the recommendation for CGM as far as hypoglycemia is concerned. ACE guidelines, they are more stringent, and they recommend the same HbA1c for older age, but ADA has changed it, and so has the IDF. You can see they match the ADA guidelines as far as the glycemic level or the cholesterol or the blood pressure control is concerned. And finally, our own guidelines, they don't speak much, but we need to know they have a recommendation of which drug can probably or should be avoided in frail patients or those suffering from chronic kidney disease. So with that, I end my talk over here. And I was just discussing with the group leader, Dr. Pratap, who is taking care of this special interest group, that probably we can come up with better guidelines and maybe a small monograph or a book on geriatric diabetes. So with that, thank you very much. Thank you.